A transient ischemic attack, a TIA or min stroke, is not a warning that something might happen. It is a warning that something has already happened and is highly likely to happen again. The only question is when. According to the American Stroke Association, around 10 to 15% of people who have a TIA will have a full stroke within 3 months, and the risk is highest in the first 48 hours, when approximately 10% of TIA patients will experience a major stroke if the underlying vascular cause is not identified and treated. According to the PMC Medical Research Council Cognitive Function and Aging Study, in a community sample of nearly 12,000 seniors over 65, 12.7% reported at least one transient neurological symptom. Yet, hospital-based TIA diagnosis rates were substantially lower, indicating that a large proportion of TAS in the community are never evaluated or treated. The gap between how often TAS occur and how often they receive the urgent evaluation they require is filled entirely by these 7 signs being dismissed, misattributed, or attributed to something other than the cerebral vascular emergency they represent. What makes TIA recognition particularly critical for senior women, the demographic represented in the thumbnail, is a finding documented in UPMC's clinical TIA overview. Women who have a TIA are more likely to experience generalized or non-focal symptoms such as weakness, confusion, and trouble remembering or thinking, rather than the classical focal deficits of arm weakness or facial drooping that most people recognize as stroke signs. This means that female seniors are specifically more likely to have TIA presentations that fall outside the FAST acronym, face, arms, speech, time, and outside the public awareness that FAST has created. The non-focal TIA signs that women experience more frequently are precisely the signs that everyone ignores. This video covers all 7, both the focal signs that appear in the FAST framework and the 3 that do not, so that any senior, any family member, or any caregiver watching has the complete clinical picture needed to recognize a TIA when it takes the form it most commonly takes in the elderly population. This video is for educational purposes only. Every sign on this list is a medical emergency. Call 911 immediately if any sign occurs. Do not wait to see whether it improves. Do not drive to the hospital, and do not postpone evaluation because the symptom has already resolved. The resolution of the symptom does not resolve the emergency. Sign number 7, sudden loss of vision in one eye. A rapid darkening, blurring, or complete loss of sight in one eye that appears without warning, lasts seconds to minutes, and then clears completely, leaving no apparent residual effect. The person may describe it as a curtain or shadow descending over the eye, or as a sudden graying of the visual field in one eye before the vision returns to normal. This specific pattern, vision loss in one eye rather, than both lasting seconds to minutes before fully resolving, is called amaurosis fugax, and it is one of the highest specificity TIA presentations available. According to Wikipedia's TIA clinical overview, unilateral weakness and amaurosis fugax have among the highest odds ratios of representing a true TIA compared to other transient symptoms. The mechanism, a tiny embolus from an ulcerated carotid artery plaque, a cardiac clot from atrial fibrillation, or a fragment from a platelet, aggravate passes into the ophthalmic artery. The first major branch of the internal carotid and transiently blocks blood flow to the retina. The retina experiences a brief ischemic event. Vision drops. The clot dissolves or moves and vision returns to normal. The carotid artery from which the embolus originated is still diseased. The cardiac source that released it is still active. A practical self-test. If vision suddenly changes, immediately cover one eye and then the other in alternation. If the change is present only when one specific eye is uncovered and disappears when the other eye is alone uncovered, the event is mononocular one eye only, which is the defining characteristic of amaurosis fugax, rather than a bilateral visual field deficit from an occipital cortex ischemic event. A mononocular visual event in a senior over 60, however, brief, is a same-day emergency evaluation that should be reported as a possible TIA, not as an eye appointment for next week. The vascular investigation that follows an amaurosis fugax episode includes carotid Doppler ultrasound to assess for significant stenosis in the ipsilateral carotid artery, the carotid on the same side as the affected eye. a cardiac evaluation including echocardiogram and cardiac monitoring to assess for atrial fibrillation or intracardiac clot, asymbolic sources and brain MRI with diffusion-weighted imaging to assess for coincident brain ischemia, the treatment initiated after this workup. Antiplatelet therapy, anticoagulation. If atrial fibrillation is found, statin optimization, blood pressure control, and carotid intervention. If significant stenosis is confirmed, produces is the 80% stroke risk reduction that the TIA's occurrence makes available. That 80% reduction is available from the moment the TIA evaluation is completed and treatment is initiated. It disappears if the evaluation is delayed until the stroke has already occurred. Sign number 6, sudden difficulty speaking, understanding speech, or finding words. An abrupt onset of the inability to produce the words that are being mentally formulated of slurred speech, where words emerge distorted from their intended sound, or of the inability to comprehend what someone is saying, even though the sounds are clearly audible. This is the speech component of the FAST acronym, and it is among the most recognizable TIA presentations in both public awareness and clinical training. According to the American Stroke Association, trouble speaking or difficulty understanding others is listed as a primary TIA symptom requiring immediate emergency contact. According to Cleveland Clinic, one-sided weakness or paralysis and sudden loss of speaking ability are among the documented TIA symptom categories. The mechanism, language production, and comprehension are governed by Broca's area and Wernicke's area, two cortical regions in the left hemisphere supplied by the middle cerebral artery. When a TIA temporarily ischias these territories, language function is disrupted in a way that is clinically impossible to distinguish from an ischemic stroke during the period of the event. The critical pattern recognition for family members, the speech disturbance that appears suddenly during a conversation that was proceeding normally lasts a defined period of minutes and then resolves completely. Returning the person to their normal speech is a transient neurological event with a vascular time course. Any episode of speech difficulty lasting more than 1 minute that completely resolves requires the same emergency evaluation as a speech difficulty that persists because the resolution of the symptom does not resolve the vascular risk that generated it. A senior who reports to their physician at a scheduled appointment 3 days after a TIA speech episode, rather than calling 911 at the time of the event, has already passed the period of highest stroke risk and the period of greatest benefit from urgent secondary prevention. The speech difficulty that lasted 4 minutes and resolved has the same clinical urgency as the speech difficulty that is present in the emergency department because both reflect the same vascular event. The only difference is that the person with resolved symptoms has a narrowing window in which the antiplatelet anticoagulant or surgical intervention that prevents the major stroke is most effective. Sign number 5, sudden weakness or drooping on one side of the face. An abrupt loss of muscle control producing a visible asymmetry, one corner of the mouth drooping, an asymmetric smile, an inability to raise one eyebrow, or a sense that one side of the face feels numb or heavy. This is the face component of FAST and alongside arm weakness. It is the most publicly recognized stroke and TIA sign. According to Memphis Neurology's TIA clinical overview, a drooping smile, difficulty lifting an eyebrow, or an inability to move part of the face can signal a TIA with symptoms sometimes lasting only minutes before fully resolving. The mechanism, the motor cortex strip, and its descending corticobulbar fibers that control the contralateral face, the face opposite to the hemisphere, affected lie within the vascular territory of the middle cerebral artery. Temporary ischia in this territory produces the contralateral facial weakness that defines the sign. A practical 2, second bedside test. Ask the person to smile broadly, showing their teeth, and simultaneously raise both eyebrows as high as possible. Normal response. Both sides of the smile rise symmetrically, and both eyebrows elevate equally. Positive finding. One corner of the smile fails to rise to the same height as the other, or one eyebrow cannot lift to match the other. When this asymmetry is new, appeared suddenly, and was not present minutes or hours before, it is a TIA finding until proven otherwise, regardless of whether it has already partially or fully resolved by the time the test is performed. Even a facial asymmetry that is resolved by the time emergency services arrive warrants the full TIA workup because the vascular event that produced it has not resolved. Sign number 4, sudden numbness, tingling or weakness in one arm or hand. A unilateral pins and needle sensation appearing in one hand or arm without any positional or pressure cause. A sudden weakness in one arm that causes it to feel heavy or unreliable, or the specific formication quality described as a crawling or stinging sensation moving across the hand and forearm without any external contact. The thumbnail's left panel showing the yellow circle highlighting the hand and fingers illustrates precisely this sign. The sudden focal sensory change in the hand that is the earliest and most subtle peripheral expression of a motor or sensory cortex TIA. The hand and finger representation in the somatosensory cortex is anatomically large and detailed. The cortical area devoted to fine hand sensation is disproportionate to the hand's physical size, which means that even a very small ischemic territory in the sensory cortex can produce a disproportionately prominent sensory disturbance in the hand. According to the American Stroke Association, weakness, numbness, or paralysis of the face, arm, or leg, usually on one side of the body, is the primary listed TIA symptom. The arm drift test. Ask the person to extend both arms in front of them at shoulder height, palms facing upward, and close their eyes. Hold this position for 10 seconds. In a normal response, both arms remain elevated at the same level. A positive finding is one arm drifting downward involuntarily while the other remains elevated. The drift reflects the asymmetric motor weakness of a contralateral hemisphere TIA. Any senior who can reproduce this test on themselves or a family member in the moment when arm weakness is present has a clinical finding that justifies immediate 911 contact. Any arm weakness combined with any other sign from this list is a combination that requires no further assessment before calling emergency services. The specific pattern that distinguishes TIA-related arm weakness from the chronic arm weakness of shoulder pathology or cervical radiculopathy is its temporal profile. Shoulder disease and cervical radiculopathy produce arm weakness that is present chronically worsened by specific movements and part of a longer history of neck or shoulder symptoms. TIA arm weakness appears suddenly, without any preceding shoulder or neck complaint, reaches its peak deficit within seconds to a minute, may be accompanied by numbness or tingling in the same limb, and resolves fully within minutes to hours. A senior who says, "My arm suddenly felt weak, and then it was fine again within a few minutes," is describing a temporal profile that no muscular cheilital condition produces. The sudden onset and complete resolution over minutes is the vascular time course of a transient ischemic event, and it requires evaluation as such. Sign number 3, sudden confusion, unusual behavior, or an episode in which the person was unable to form or retain new memories for a period of time. Waking up in a state of bewilderment without knowing where they are or what they have been doing, repeatedly asking the same question without retaining the answer, or behaving in a way that was uncharacteristic and that the person has no memory of afterward. This is the sign that everyone ignores, not because it is unnoticeable, but because it has more possible alternative attributions than any other sign on this list, and because the person who experiences it often has no memory of the episode themselves and cannot advocate for their own evaluation. According to Cleveland Clinic's TIA overview, confusion or agitation and memory loss are among the documented TIA symptom categories. According to UPMC's TIA clinical overview, confusion or memory loss is listed among the documented TIA presentations that prompt urgent evaluation. The specific presentation called transient global amnesia, in which the person cannot form new memories for a period of minutes to hours, repeatedly asks the same questions, appears bewildered and anxious despite otherwise intact consciousness, and has a complete blank in their memory for the entire episode afterward, requires TIA evaluation in any elderly adult with vascular risk factors, including hypertension, diabetes, hyperlipidemia, or atrial fibrillation. According to Wikipedia's TIA clinical overview, public awareness on the need to seek medical assessment for non-focal symptoms such as amnesia and confusion is low, and this low awareness results in delays to treatment. The exact delay that allows the subsequent stroke to occur without secondary prevention having been initiated. The reason this sign is specifically the one that everyone ignores is threefold. First, the person experiencing the episode has no memory of it, and therefore it does not report it. Second, family members who witness it are more likely to attribute it to fatigue, stress, dehydration, or medication effect than to a vascular event. And third, the resolution, the person returning to their normal mental baseline, is experienced as relief and reassurance rather than as the signal that something that required urgent evaluation has just occurred. The behavioral observation that family members should document and report. Did the episode begin suddenly, without any gradual onset? Did the person ask the same question more than twice within a short time period, receiving the answer and then asking again without any awareness of having asked before? Did the episode last a defined time period and then end returning the person to their baseline? And does the person have a complete gap in their memory for the duration of the episode? These four characteristics, sudden onset, repetitive questioning, without retention, defined duration, and post-op episode amnesia, are the transient global amnesia pattern that requires TIA evaluation at the same urgency level as facial drooping or arm weakness. Any family member who witnesses an episode fitting this description in an elderly relative should call emergency services and specifically report the person had an episode of confusion with memory loss that lasted approximately this duration and has now returned to normal. Do not wait to see if it happens again. The subsequent stroke may be the event that happens again. The specific reason this sign is particularly dangerous in senior women, the demographic represented in the thumbnail, is the UPMC finding that female TIA patients are more likely to experience generalized symptoms, including confusion, weakness, and memory difficulty, rather than the focal motor deficits of arm weakness and facial drooping that most people and most emergency triage systems are calibrated to recognize. This means that an elderly woman who presents to an emergency department in a post-ep episode state of confusion or who was brought in by family reporting unusual behavior is statistically less likely to receive a TIA evaluation as the first diagnostic hypothesis than a man presenting with arm weakness and facial droop, creating a gender-specific gap in TIA recognition that produces higher rates of missed TIA diagnosis and subsequent stroke in elderly women. Knowing this disparity is actionable. If a family member brings an elderly woman to an emergency evaluation after an episode of sudden confusion or unusual behavior, they should specifically state that they're concerned about a TIA as a possible cause, because the framing of the chief complaint influences the diagnostic pathway that follows. Sign number 2, sudden difficulty with balance, coordination, or walking. An abrupt inability to walk normally, a veering to one side during walking, a loss of coordination that makes the legs feel unreliable, a spinning sensation that is severe enough to prevent standing, or a sudden fall from a standing position without any obstacle, surface change, or loss of consciousness to explain it. According to the American Stroke Association, loss of balance or coordination is specifically listed as a TIA symptom requiring immediate emergency contact. According to Cleveland Clinic, loss of coordination or clumsiness and dizziness or vertigo are both documented TIA symptom categories. The mechanism, the cerebellum and brainstem, the structures responsible for coordinating movement, maintaining balance, and generating smooth voluntary motion are supplied by the vertebra-basilar circulation. TS in the posterior circulation affect these structures and produce the dizziness, ataxia, and balance failure that characterize this sign. A distinguishing clinical question: was the dizziness provoked by a head position change, or did it appear spontaneously without any head movement? Benign positional vertigo from the inner ear is consistently triggered by specific head movements, rolling over in bed, looking up or down, and produces a rotational spinning that lasts seconds to minutes before subsiding. TIA-related posterior circulation dizziness appears without any positional trigger, may be accompanied by double vision, difficulty swallowing, weakness in a limb, or slurred speech, and does not reproduce consistently on positional testing. Any episode of sudden severe dizziness that appeared without a head movement trigger, particularly if it prevented normal standing or walking, even briefly, requires TIA evaluation rather than a vestibular assessment as the primary investigation. The thumbnail's right panel showing sudden loss of bodily control most directly illustrates this sign at its most severe. The sudden bilateral weakness of both lower extremities from a posterior circulation TIA involving the corticospinal tracts in the brainstem which can produce a sudden drop attack. A person going from standing to the ground without losing consciousness that is indistinguishable from a fall unless the neurological mechanism is specifically investigated. Drop attacks in the elderly are often attributed to tripping to muscular weakness from aging or to orthostatic hypotension, and all of these attributions may be correct. But when a drop attack or sudden severe balance failure occurs without an identifiable mechanical cause, and particularly when it is accompanied by any other neurological symptom lasting even seconds, a brief double vision, a momentary slurred word, a transient hand numbness, the posterior circulation TIA explanation must be investigated before any other cause is accepted. Sign number 1, a sudden severe headache that is the worst of the person's life, appearing without warning, reaching maximum intensity within seconds to a minute, and described as an explosion, a thunderclap, or a sensation that has no prior equivalent in the person's headache history, or a qualitatively new headache accompanied by any other sign from this list. According to the American Stroke Association, a severe headache with no known cause is specifically listed as a TIA and stroke symptom requiring emergency contact. According to Cleveland Clinic, neck stiffness is documented among the TIA symptom presentations that accompany sudden onset headache. The thunderclap, headache reaching peak intensity within 60 seconds of onset, is the clinical presentation that most urgently requires imaging to exclude a subachoid hemorrhage, because the rupture of an intraradial aneurysm producing subachoid bleeding generates precisely this headache pattern, and it represents a hemorrhagic emergency in which every minute without treatment carries risk of permanent neurological damage or death. A severe headache accompanying any other sign from this list. The visual loss, the arm weakness, the confusion indicates a neurological event affecting multiple vascular territories simultaneously and requires 911 contact without any delay for self-assessment or symptom monitoring. The thumbnail's right panel showing the sudden loss of bodily control that the most severe vascular events can produce represents exactly this, the catastrophic physical consequence of the major stroke that follows the TIA that was not evaluated and treated when it occurred. The FAST. Acronym face, arms, speech, time to call 911 captures signs 5, 4, and 6 of the 7 on this list. Signs 7, 3, 2, and 1 fall outside FAST. According to the PMCC FAS TIA study, prompt initiation of secondary prevention following TIA is associated with up to an 80% reduction in the risk of subsequent stroke, an 80% reduction in the risk of the event that causes the permanent disability, the institutional care, the loss of independence, and in too many cases, the premature death that the TIA was warning would follow. The 80% belongs to every senior who calls 911 when any of these 7 signs occurs, and to every family member who knows all 7 rather than only the 4 that the acronym covers. Watch the next video on screen, right?